Boston, and I'm Peter Novak. I'm from an autonomic laboratory at Brigham Hospital, and I will talk in next minutes about orthostatic intolerance syndromes. Here are my disclosures, and I will talk about several off-label medications. So there are many orthostatic intolerance syndromes. In the context of dysautonomia, we understand around the syndromes that are associated with decreased orthostatic cerebral blood flow. Typical symptoms are dizziness, fatigue, shortness of breath, which is provoked by orthostasis by standing, and improve symptoms on a lying down or even sitting position. What is common for all these syndromes is the presence of cerebral hypoperfusion. There are some other rare causes with normal cerebral blood flow, but I will focus today mainly on this syndrome associated with low blood flow. And probably the most common is syncope, which is associated with global hypoperfusion, with loss of consciousness. But people are not aware that the most common actually is pre-syncope. Pre-syncope can be loosely defined as a not fully developed syncope, which people get dizzy, sometimes sweaty, have vision troubles, but they don't develop full loss of consciousness, but they recover even during tilt test, or they simply sit down to avoid the full syncope. So this is the most common orthostatic syndrome. Then there is category of syndromes associated with low flow but stable blood pressure, and those are classic POTS. And I will talk today about 3 other syndromes. And there is orthostatic hypotension, which is relatively well known, which is associated with decrease of the blood pressure. And there is orthostatic hypertension. So even with high blood pressure on standing, the patients can experience dizziness. And this dizziness is also related to decrease of the cerebral blood flow, causing cerebral hypoperfusion. I will just recapitulate the main properties of the autonomic nervous system, because this can understand the diversity of syndromes or symptoms. So autonomic nervous system controls essentially all organs, and those are efferent fibers. So motor fibers, you don't feel them, but they cause end organ damage. From the context of orthostatic problems, the most important are parasympathetic fibers to the heart. They control the heart rate. They control the heart rate response to standing. And then the sympathetic vascular innervation, which cause peripheral vasoconstriction or vasodilatation upon the context, which is also compensatory for the orthostatic stress. And autonomic symptoms are diverse because diversity of innervation of the organs could be divided to orthostatic, non-orthostatic, and diffuse. Regarding orthostatic symptoms, typical are lightheadedness, dizziness, palpitation, sense of weakness, and I would stress that probably shortness of breath is very characteristic. You see it almost in everybody. Then it's chest pain, chest tightness, and exacerbation by heat, exercise, meal, hyperhidrosis. Then there are several non-orthostatic syndromes or symptoms, and then diffuse like fatigue, sleep problems, migraine, which are less understood. We usually do recommending autonomy testing if the diagnosis is questioned, or if the response to medication is not as we expect. I'd like to show you the examples of the tilt test, because tilt test is probably the most important part of the autonomy testing. I will use this picture or schema in the remaining of the presentation. So we here have a continuous heart rate, blood pressure, and tidal CO2 as a mark of respiration. And here is continuous cerebral blood flow monitoring from the middle cerebral artery during supine, typical record 5 to 10 minutes supine, tilt typically 10 minutes, and second supine position. So this is normal response. There is a mild increase of the heart rate, typically more than 10, less than 20, which is normal response. And see that the blood pressure during the tilt is quite constant. It's fluctuation of the mean blood pressure, but there is not too much changes. End tidal CO2 is also kind of stable. And you can see that the blood flow kind of is more or less stable. There's some fluctuations, but the mean blood flow from the middle cerebral artery is stable. So this is normal response. If you want to look on the circuits of the response to tilt or to orthostatic stress, so they are both central in the brainstem and peripheral circuits. These are sympathetic pathways and parasympathetic pathways, which control mainly, again, the heart rhythm. There are sensors in the lungs, in the heart, and control the heart rhythm. Parasympathetic sympathetic pathways mainly control the sympathetic mediated vasoconstriction as a compensation of standing. A few words about neurogenic orthostatic hypotension. I would not go to the details. There will be separate presentation about this. I like to just show you from the context of the blood flow, and we can then compare with non-OH syndrome. So OH is defined as typically as the drop of systolic blood pressure 20 or diastolic by 10 millimeter of mercury at the 30 minutes of standing or the tilt test. And autonomic adrenergic failure is the most common cause. There are some cardiac causes, but I would not talk about it now. And OH is quite frequent in patients with diabetes or patients with Parkinson's disease. And also it's very common in patients with hypertension, particularly if hypertension is uncontrolled. So there are two main types of the orthostatic hypotension. So it is, I would call it compensated or asymptomatic, and symptomatic or uncompensated. In asymptomatic compensated hypotension, in spite of the drop of the blood pressure, profound systolic blood pressure drop, the cerebral blood flow remains kind of stable, maybe drift a little bit down, but it is stable enough to does not cause cerebral perfusion. So there is no hypoperfusion. Patients are doing well. They don't have any symptoms. So this is example of autonomic failure, which with minimal heart rate response on standing. But this patient drop of the blood pressure is within cerebral autoregulatory curve, so he is able to compensate. On contrast, this patient shows a profound decrease of the blood pressure, both systolic and diastolic down, is up to 70. So it is very close to even syncopal range. And you see the reduction of the cerebral blood flow is much more than this uncompensated patient. And brain is very sensitive to blood flow changes. So even 10–15% can cause a very mild dizziness, but you see more than 20–30%, it can cause significant dizziness, shortness of breath, signs of hypoperfusion, and people typically, they're passing out when the blood flow goes down more than 40%. So again, this is example of the orthostatic hypotension without compensation is symptomatic with low flow and asymptomatic with stable flow. Now, syncope, again, I would not go to the details of syncope because we already had some of the syncopal issues, and will be probably also another presentation. So syncope is defined as a loss of consciousness due to global cerebral hypoperfusion, and is typically associated with drop of the blood pressure. There are two main causes of syncope, cardiac and neurogenic or reflex. And just like to show you example of what happened during the syncope. It is of vasodepressor type, so it is neurally mediated syncope of vasodepressor type. So again, we have the same paradigm as before, so supine, tilt, supine. And initially, this patient had a normal response in heart rate, blood pressure, and end tidal CO2 and blood flow. And then something happened this point approximately. This caused kind of profound decrease of the blood pressure associated with hyperventilation as drop of the CO2 and drop of the blood flow until patient pass out, causing syncope. This is a detail of the same patient. And then the tilt was aborted. We placed the patient down to the supine position, which after some time restored blood pressure and the blood flow. This is an abnormal example of the blood flow response, because in a normal response is vasodilation, so it is expected to increase of the systolic blood flow. I will show you later on. But the point I want to show you here is that there is a classic syncope. There is no heart rate change, heart rate response during the syncope. So this is a classic vasodepressor syncope. In contrast, this is most common mixed syncope associated with drop of the heart rate, so bradycardic response, together with drop of the blood pressure. And this is normal response in the blood flow. The diastolic blood flow goes down almost to 15, even less, centimeter per second, while the systolic flow goes up. So this is a normal compensatory response of cerebral arteries. And patients typically pass out if the blood pressure is less than 60 of systolic millimeter. And this is a detail of the syncope. And also what is very interesting classic teaching is that most of the syncope occurs when sitting or standing position, but once in a while we see very unusual pattern, people can actually pass out even lying down. In this patient pass out or develop syncopal reaction at standing. It's classic mixed vasovagal reaction, drop of the heart rate, blood pressure, and this vasodilation response. The tilt was aborted. Patient regained a little bit consciousness, and there was some increase of the vital blood pressure. But then again, patient lost consciousness, and was shown that there was another drop of the blood pressure. It was in a supine position, and with persistence of dilation response. It took probably another like 2 or 3 minutes till patient came back and vitals were restored. So this was pattern of syncope, but I like to focus your attention on pre-syncope. So this is very common. Actually, this is the most common orthostatic syndrome we see. And ironically, it is the less likely to be studied. So this shows like an initial response to the tilt. When we will change the scale, you see these drops of the blood pressure. They don't reach the syncopal level of 60/40, but they still drop enough, causing this vasodilation response in the cerebral blood flow. And this is so typical pattern. You can even predict when a patient will tell you when it's dizzy. For example, patient was dizzy at this point exactly, then recover. It was again dizzy over here, then recover. It was dizzy again here. So this is associated with these drops of the blood pressure and vasodilation response. And in contrast of syncope, so patient will recover. So it does not culminate in syncopal reaction. So this is very common pattern. Now, a few words about the POTS, and I will use it as a reference for other syndromes. So I will not go to the details because it will be special POTS presentation. So POTS is defined as symptoms of orthostatic intolerance more than 6 months, associated with postural lightheadedness, dizziness, shortness of breath, tiredness, palpitation, leg weakness, and other complaints. And again, this is orthostatic syndrome, so the symptoms get worse on standing at orthostasis and are relieved by return to supine position. Considering the signs, so it is defined as sustained, exaggerated heart rate response increment by more than 30 beats per minute during 10 minutes of the head-up tilt test or active standing, and frequently exceeding 120 beats per minute in absence of orthostatic hypotension. And autonomic testing usually show decline of orthostatic cerebral blood flow velocity associated with hypocapnia. This is a very important finding, I will show you later on. There are different forms of the POTS. And what is very important, it is very, it affects people younger than the middle age, more females, and is very prevalent. It is very common. There are different estimates, range from 1 to 2.5 million in US. I saw one paper predicting up to 3 million. And also it is frequently uncertain disorder, so there might be immune-mediated disorder, and sometimes immunomodulatory treatment can be effective. POTS is again syndrome, so there are many of the disorders associated with POTS, and there are systemic inflammatory conditions. More recently, many patients or have studies describe EDS associated with POTS. Mitochondrial disorders. There are some indications that mast cell disorders might be more common than we think. Many people might have POTS. And there are several paraneoplastic syndromes. Fortunately, they are kind of rare. And important thing is to realize why POTS patients are symptomatic on the standing is because they have signs of cerebral hypoperfusion, which is induced by hyperventilation. And this is what's going on. So this is classic POTS patient. You see the excessive tachycardia during the upright position, exceeding 120, but the blood pressure is stable. Systolic goes a little bit down, diastolic a little bit up, so this is a normal response. So mean blood pressure is constant, essentially. But we see here hypocapnia during the orthostatic position, and hypocapnia drives the low flow. And how we know it? Because when we are adjusting flow by the effect of hypocapnia, we can do it mathematically. Adjusted blood flow is standard and is constant. It is the same, similar as during the baseline in supine position. So again, in POTS, decreased blood flow and signs of cerebral hypoperfusion, which result from the low blood flow, is driven by hypocapnia. I will not go to the details why hypocapnia originates, what is the cause of hypocapnia. I think it is has a metabolic origin, but it is not clear what is driving hypocapnia. So we talk about the POTS as a classic prototype of orthostatic intolerance. Now I'd like to bring your attention to hypocapnic cerebral hypoperfusion. And let's look on this scenario. So let's look on the classic textbook example of the POTS patient. So 22-year-old woman has symptoms for 8 months, and the symptoms started about 2 weeks after flu-like illness. And weeks after she recovered from illness, she developed orthostatic tachycardia, dizziness, shortness of breath, etc. So those are all typical signs of the POTS. And indeed, the TIL test did show excessive tachycardia on standing, but blood pressure was stable. You see also this fluctuation of the blood pressure, but this is common finding in the POTS. But the point is here, the blood pressure was stable, and this is diagnostic for the POTS. Let's look at another scenario. So let's this 28-year-old woman has symptoms for 11 months, and symptoms started about 4 weeks after flu-like illness. And she also developed signs of orthostatic dizziness, heart was beating heavy, shortness of breath. She was tremulous, anxiety during the standing, and she had frequent headaches and other things. So in both, and also the TIL test was done, but this time they showed normal heart rate responses, normal blood pressure. So comparing these two cases, both are almost identical. So this is a younger female with orthostatic intolerance preceding some flu-like illness. So why this did show normal responses? But if you look on the blood flow responses, so both are identical. So in this POTS patient, a drop of the cerebral blood flow, this is mean blood flow. Adjusting for the CO2 was stable. And indeed, when we are superimposing the mean blood flow over the CO2 and tidal CO2 levels, is almost identical match. So this only shows that really CO2 level is driving blood flow responses. Now look on this patient with normal heart rate response, but the same clinical phenotype, I would say. We see the same pattern. So this decrease of the cerebral blood flow, but adjusted blood flow is normal. It is same as during the baseline. And when we superimpose the mean blood flow over CO2, there's a very good match, again suggesting that the CO2 drives low blood flow. So this condition we call it Hypocapnic Cerebral Hypoperfusion, and this is working definition of the syndrome. I would just say that my opinion is that it is simply spectrum it is the same syndrome as a POTS, but different spectrum of the same disorder. And again, the clinical manifestation is very similar. It's only missing this tachycardia, this orthostatic blood flow is reduced, then probably has the same form as a POTS. So again, this HYCH or hypocapnic cerebral perfusion is probably milder variant of the POTS or POTS without the T. And what's very interesting is that many times we have a referral from the other physicians, patients with, again, POTS-like presentation, they are even treated with POTS-like medication. And we do a TIL test, which is essentially normal, except of the blood flow. So they satisfy criteria for the HYCH. And I think this is very common condition. And so this is, again, a comparison with the normal control. There's a drop of the blood flow driven by end-tidal CO2 decrease, because adjusting for the death, the blood flow is normal, and there is normal blood pressure responses and normal heart rate responses. And therapy, we treat each patient exactly as the POTS. So number one is exercise. Is probably most important approach. Then of course diet and medication. Regarding the diet, always recommending excessive hydration and high salt diet. Exception would be if there's underlying hypertension or underlying hyperadrenergic form of POTS or HYCH. Then of course we don't want to give more salt. Again, like general recommendation, like avoid large meals, like small meals, avoid alcohol, high food on high carbohydrates and caffeine. And again, physical therapy and exercise is extremely effective if patients are motivated. And there are several reconditioning programs in the South. Unfortunately, we don't have them, but I got very good feedback from the patient. They like them very much. They experience improvement. We do medication only if non-medical approaches fail. And in general, for POTS HYCH, we do the same approach. So there are multiple medications in the literature, but we use only a few of them actually. And this is a simplified recommendation. So we can divide both syndromes with elevated blood pressure and normal low blood pressure. With elevated blood pressure, it could be hyperadrenergic form. So we're using typically beta blockers, calcium blockers. In the severe cases, clonidine, but very rarely. Patients with POTS with normal or low blood pressure could be hypovolemic form or neuropathic form. We typically use mestinon, florinef, midodrine. I like mestinon. It's very safe medication, even mildly effective, but it is safe to be combined with other medications. And also sometimes we use Corlanor if this treatment fails. But many, especially advanced POTS patients, they need a combination of medication. And prognosis also, which is in general is very good, unless there is another secondary disorder. For typical post-viral complications, most patients will recover, and only few will have significant post-POTS problems. Actually, come from the group. Now, in next few minutes, I will talk about orthostatic cerebral hypoperfusion syndrome. This is very different from the POTS and from the HYCH I just show you. And let's start with this scenario. So, a 57-year-old man has symptoms for 18 months. And the symptoms are orthostatic dizziness, shortness of breath, tremorousness, anxiety during standing, frequent headaches, chest pain or chest tightness, nausea, brain fog, fatigue. Again, TIL tests show normal heart rate and blood pressure response. It is a little bit older man, so he had extensive workup, including cardiac workup, seen by rheumatology, because some joint problems. He had an MRI of the brain that showed some white matter changes. But when we add this patient respiratory and pulse flow monitoring, we see profound changes in the cerebral blood flow. And there was a drop of the blood flow, it was more than 20–30%. So this is really very significant. But in contrast to Postural HYCH I showed you before, there is no difference in the end-tidal CO2. So this drop of the blood flow is not driven by the CO2 levels. And when we adjusting level of the blood flow based on the level of the CO2, there is no difference. So there's overlap of these tracings. At the same time, the blood pressure is stable. There's no orthostatic changes. There's no orthostatic hypotension. And the heart rate response is also normal. So it is within range 10 to 20. So this is a very different condition than before. And it is as a result from the failure of cerebral arterioles to open up during the standing. So when during the standing, because of orthostatic stress, there is a drop of the blood pressure inside the head, and this will cause a drop of the blood flow unless there is this vasodilatory opening of the cerebral arterioles, which will keep the blood flow standing. So this is how the cerebral autoregulation works. So HYCH syndrome is mainly syndrome of failure of the autoregulation to keep blood flow stable. So again, this is a comparison of the HYCH with the POTS. The magnitude of the drop of the blood flow is very similar in both syndromes. Actually, many times in HYCH we see much more drop of the blood flow. Sometimes it might even reach the syncopal levels. Again, for syncope, people have drop of the blood flow 40% or more. But also it seems that also the rate of the blood flow changes might be significant. Again, brain is very sensitive to changes of the blood flow, even can tolerate wide swings of the blood pressure. And this is another example of the HYCH. In this patient, the blood pressure is significantly elevated. It was with a range 150–160 systolic. In spite of the high blood pressure, there is progressive drop of the blood flow. Even there's some fluctuations we see once in a while, but there is a progressive trend decrease of the blood flow, while the end-tidal CO2 is steady. So the decrease of the blood flow is due to failure of the cerebral arteriole, so it is a vascular problem. And this is very preliminary, but we think that this condition is not as frequent as the POTS, but we see probably 2–3 patients every few months. And it affects people between age 20 to 60, so this wider range of the ages. And also it perhaps affects more males, in contrast to POTS, which affects more females. And also we think there are two clusters regarding the prevalence. It affects people younger in age range 20 to 30 years, and it affects mainly patients with the migraines. So migraine has a vascular component, so it is, but it's kind of mechanistical explanation. So migraine somewhat affects the orthostatic responsiveness of the arterioles, which can cause the cerebral autoregulatory failure. Second clusters with HYCH affects the patient older than 50-year-old. And because we did everybody MRI these patients of the brain, it was kind of striking that many of these patients, they did have signs of the small vessel disease associated with multiple white matter changes. And again, most of those patients, did have hypertension. And there was one patient we just find out that he has post-COVID syndrome with the same pattern. And therapy, again, is very preliminary, was not studied, but it seems that control of the blood pressure seems to be essential. And this, again, mechanistical attitude. We are using calcium channel blockers because they cause cerebral vasodilation. We have pretty good experience with verapamil diltiazem. And if they will fail or cannot be tolerated, we are using ACE inhibitors. The reason for ACE inhibitors is Dr. Lou Lipsitz study. He did show a few years ago that he applied ACE inhibitors in patients with uncontrolled hypertension. Those patients have elevated blood pressure and also monitor the blood flow. So they have high blood pressure, low flow, indicating vasoconstrictive effect. So patients with on lisinopril, they decrease the blood pressure, but also the blood flow went up. So they, some respect, restore cerebral autoregulation, but the main effect was increase of the cerebral blood flow. Now, a few words about inappropriate sinus tachycardia, because this is relatively frequent condition, especially if you do autonomic testing. Again, it is a poorly understood condition. It is mainly encountered by our colleague from cardiology. It can have similar presentation for the POTS, could be orthostatic complaints, and it is probably two variants. One is cardiac origin. So again, this is tachycardia, which could be present also in the, not only during orthostasis, but also the baseline. And number one variant might be related to abnormal conduction of the cardiac conductive system. Second could be variant of the POTS. What is different between this variant POTS and IST is resting tachycardia about 100 beats per minute. And also, now POTS is typically provoked by orthostatic stress or tilt test, but in IST, tachycardia is also provoked by emotional stress, not only physiological. Although we see frequently emotional induced tachycardia even in POTS patients, so it is not sometimes helping to distinguish. Also, according to some of the reviews, ivabradine seems to be better than beta blockers in IST, but we also use ivabradine in the POTS patients as well. And this is example of the IST. So again, question is if this is a variant of the POTS or not. The main difference between IST and POTS is the presence of the supine or baseline tachycardia, which is absent in the POTS. My opinion is, and we approach this patient as a POTS if they have the same pattern as a POTS. It means if a patient with tachycardia, but they still increase the heart rate more than 30, so they satisfy criteria for the POTS. But if they have a decrease of the cerebral blood flow, which is driven by hypocapnia, then we approach these patients as a POTS patients. If they would have a normal blood pressure, blood flow, and no hypocapnia, then we tend to approach this patient as the IST because of cardiac conduction problem. Even the treatment might be kind of similar, but our experience says that patients with IST or the POTS version, they tend to have more widespread complaints, probably representing that other autonomic involvement, other organs. And I think I took also my time, so thank you very much for your attention, and please let me know if you have any questions.
Thank you, Dr. Novak, for that excellent presentation. We're going to move into the question and answer period. So for our listeners, you can go to your Q&A tool at the bottom of your Zoom screen and type questions into that box. please try to keep the questions general and not specific to your own experience. The speakers cannot provide specific medical advice, and we won't have time to get to all of the questions, but we'll try. So the first question that came up a few times is cerebral hypoperfusion, or OCHOS, is that harmful to the brain?
It could be. We know from other conditions that repetitive hypoperfusion can have negative impact on the memory, on cognitive functions. So we think a cumulative effect of hypoperfusion might have negative consequences. And I think that many of these patients that have uncontrolled hypertension, and the Tulipsy study did show they actually improve in terms of the blood flow. So they might have OCHOS, so they have decreased blood flow, and they indeed had cognitive problems, memory problems. But what was very interesting, many of these cognitive problems, also one of the problems was they had troubles with gait, a lot of falls. But when they normalize the blood pressure, normalize the blood flow, number of the complaints improved, and especially gait improved. So again, answer is significant or severe drop of the blood flow can cause problems with the brain, but also improvement of the blood flow can cause improvement of the brain functioning.
What is the long-term outcome of the cerebral hypoperfusion? Do patients tend to recover?
There are two types of patients. The patient with younger patients with POTS-like presentation, with migraine, and they probably recover many times. We don't know, we don't have any long-term studies, but based on our patient population, they tend to recover. Actually, many times they are losing the follow-ups because they're doing so well in general. Regarding the older patient with 60s or with the OCHOS with hypertensive, it appears to be that treatment of underlying hypertension will determine the prognosis. But again, for the younger patients with no comorbidity, prognosis in general is good unless there's some underlying secondary disorders. And that's why we always screen, for example, for systemic autoimmunity. This is very common now. A lot of allergies, mast cell problems, which require typically a little bit different treatment.
You mentioned POTS without the T, and several people in our chat are wondering how if you think you have POTS but don't meet the tachycardia criteria, how should they go about getting diagnosed and treated?
There's no study, but I think in many, even a primary physician, many physicians, intuitively, they treat patients exactly the same as POTS, because they treat based on the symptoms, so always starting with exercise, diet, and let's say a patient complained on the tachycardia or the typical dizziness on standing, and at the office they will find out the low blood pressure. Blood pressure is kind of like 110, 120. So they typically put empirically patient on mestinon or midodrine. So this is exactly what we are doing with the POTS patients. So treatment is, I would say, identical as a POTS. There's one exception, those patients which have high blood pressure, then you have to be more careful, and then treatment is not the same.
Okay.
Then, but there's another line of thinking is that the criteria are not that perfect. So the criterion of the 30 beats per minute is very arbitrary. So we know that it goes either way. So it is many patients, they are not diagnosed because there's a very strict criterion. But sometimes this, many patients with even like 35, 40 beats per minute increment, they might not have such a symptom. So this criterion is very arbitrary, and my opinion is it should be changed. If you look on the original criteria paper to law from Mayo Clinic, They look on the increase of the heart rate by 2 standard deviation, not 30. And also one criterion was, for example, increase of 120 beats per minute. So it now was dropped from the recent studies. I think the best criterion which we try to use it in the treatment decision is combination of tachycardia, if any, but the blood flow response to the tilt. Because I think it is blood flow what matters for the brain, not tachycardia. Tachycardia is a marker of the disease, but again, patients are symptomatic likely because they're hyperfusing the brain. So we try to use a blood flow variable as a marker of the disease. And then either it is HYCH or both, we treat it based on the underlying findings.
Several people have asked about shortness of breath. In your opinion, is this linked to OCHOS, and what is the best way to treat that?
Shortness of breath is very common in any type of dysautonomia. It is simply part of orthostatic problems. We see it in POTS, HYCH, and OCHOS. So it is probably because of the perfusion issues with the lungs. There are different sensors, upper, lower lungs, but again, we not good explanation. But again, it is very, very characteristic of the dysautonomia. And my opinion is, or my experience is, it tends to respond better to mestinone or pyridostigmine than to other medications. And I will tell you an example. So in Boston, we have specialty pulmonary physicians. They focus only patients with dysautonomia and shortness of breath. And they have very expansive cardiac and pulmonary evaluations. And they do studies, and they got very good response from the mestinone. So mestinone somewhat has a predilection to this lung innervation, which probably drives the shortness of breath.
This will probably be our last question. Someone asked, can you have IST and POTS?
I think not both. I think IST could be a variant of the POTS. So if you have IST, then probably it is either POTS, or as I mentioned, it could be because of cardiac conduction abnormality. But we are biased, so we see mainly this POTS variants of the IST because this is how the referral system works over here. But I saw a couple of patients which had likely cardiac reason because they did not respond whatsoever any autonomic or medication which we use for the POTS. They somewhat responded to ivabradine, but they were treated by cardiologists.
Okay, I think we can fit in one more question. Why is nausea and vomiting, why are they associated with POTS? I know you mentioned that very early on in your talk.
There are two explanations for this. Number one, it is simply a marker of the stress response. So it is probably something to do with sympathetic withdrawal. So it is parasympathetic kind of predominance. And we see this in almost developed syncope with severe hypotension. So it is one of the non-specific reaction. But second is, and we still did not understand this fully, the significance of that. We observed this low flow and hypocapnia in POTS patient in 90s as a research setting. And so people are hypocapnic, right? So what we did is we get them a rebreathing mask, so increase the CO2. And what happened is we normalized the CO2, there was no hypocapnia anymore, we normalized the blood flow, but patient become very nauseated, almost vomit. So we somewhat provoke this anti-compensation response. So we fix the vital signs, but subjectively patient feel much worse. So we could not explain the why this happens. But I like to stress that this hypocapnia means people are hyperventilating, but this is not psychological or psychiatric hyperventilation syndrome. The reason is because it is probably it's a metabolic hypocapnia. And our reasoning was that, so if people are hyperventilating because they are psychological hyperventilation, psychiatric problems, so or because of anxiety, then if we will do a reverse the tilt, so they should be also anxious or hyperventilating. They are upside down, right? Head down and legs are up. But it was very interesting that by that way, we observed complete resolution of the orthostatic syndromes. So patient had no tachycardia, was completely gone. Blood flow was perfectly stable. The endothelin CO2 went up to around 35, even like 40. And there was no nausea whatsoever, no any vomiting. So patients feel almost like meditating, except of that with pressure on the neck. So you cannot do it for a long time.
That's very interesting. Thank you, Dr. Novak, for answering the questions and for your presentation.